In this video, I'm going to talk to you about hypothyroidism in pregnancy. Before we talk about hypothyroidism in pregnancy, let me highlight a few things about thyroid gland and pregnancy. In pregnancy, we see a few changes in thyroid gland. One is the hormonal changes. Increased levels of beta-HCG can stimulate the thyroid gland and reduce the TSH levels, which will eventually become normal. High levels of estrogen can increase the total binding globulins and increase the total thyroxine levels, but they have normal free thyroxine levels. There can be also increase in size of thyroid gland, which is physiological, in about 10 to 15% of a percentage increase, which cannot be usually seen on examination. Let me now come to hypothyroidism in pregnancy. It is a common disorder we see in pregnant women, and hypothyroidism in pregnancy, the causes include especially the autoimmune disorders. It could be due to untreated existing hypothyroidism or patients who have been overtreated for hyperthyroidism. And in patients with Hashimoto's thyroiditis, we can see high levels of TPO antibody levels. What is this connection between the hypothyroidism and pregnancy and for the baby, the consequences? Normally, the baby or the fetus is not able to produce their thyroid hormone levels until they are 18 to 20 weeks in gestation. So for the first 20 weeks, the fetus depends on the mother for their thyroxine requirement, which is very important for their brain development. After 20 weeks, they are able to produce their own thyroid hormones. What are the risk factors for having hypothyroidism in pregnancy? What are the risk factors for mother? The risk factor for the mother usually is for miscarriages. The mother could be having maternal anemia, myopathy, congestive heart failure, preeclampsia in pregnancy. And what are the risk factors for the baby? So there have been research which they have found that severe untreated hypothyroidism can cause fetal brain abnormalities. Even mild hypothyroidism has been found to have mild cognitive impairments in children. So should we screen all women in pregnancy for hypothyroidism? It's not possible. So whom should we do the screening for hypothyroidism in pregnancy? Especially patients who had any history of hypo or hyperthyroidism, in patients who have a goiter, in patients who have a family history of thyroid disorders, or if they're having any other autoimmune disorders, we need to screen them for hypothyroidism. So how can we do that? By doing a thyroid function test with the TSH and the free T4 levels as soon as we know that they are pregnant. If they are already on thyroxine, the patient should be able to do the thyroid function tests as soon as possible and increase the daily dose by 20 to 30%. Especially we ask them to increase 2 additional doses for the week till they do their blood tests. Who should we treat in hypothyroidism? Should all patients be treated? If the patient's TSH level is above 10, yes, we need to treat these patients for hypothyroidism. If the patient's TSH level is in between and below 10, it is important we do a thyroid peroxidase antibody level. If the antibody levels are positive and if the TSH is more than 4, we need to treat these patients for hypothyroidism. If their levels are between 2.5 and 4, we need to consider treatment for the benefit of the mother and the neonates. If the patient's antibody levels are negative and the TSH level is between 2.5 and 10, we have less strong evidence for treatment, but treatment can be considered. That is an individual approach. Any woman with TSH less than 2.5, even if they have positive antibodies, does not require treatment. So how do we treat these patients for hypothyroidism? By giving them levothyroxine treatment, and it has to be within their trimester specific range. We monitor their TSH levels every 4 weeks during pregnancy, especially for the first 20 weeks. After they deliver, they can go back into their preconception dose and monitor their TSH levels after 4 to 6 weeks. Thank you.